Um, so Luke and I are presenting today, and I think Paul emailed around the article again, but it's clinical handover from emergency medical services to the trauma team, and it's a gap analysis. I chose this article for a few different reasons, and it's not, we'll go through some of the limitations, I guess, in the discussion. But I thought it was a pretty interesting topic, especially having finished training recently and been across a lot of different emergency departments and different trauma departments, I guess. So thought it would be interesting discussion. Luke's going to share his screen, I think. Are you, Luke? I don't know that I can hear everyone. Okay.
No one's spoken yet.
And he's going to sort of present the article and a bit of the results and some of the discussion. And then hopefully we can just get some discussion going. Anybody have any comments before we get rolling?
Nope. It was an interesting article, so I'm intrigued to see what you guys thought.
All right. Well, Luke, take it away.
So thanks for the introduction there, Dan. So I'm Luke. I'm one of the first-year family medicine, emergency medicine residents here in St. John, and I'm going to be presenting tonight with Dr. Dan Hines. So kind of the structure I'd envisioned for the evening is that we'll start with a brief summary of the article. I'll go through a critical appraisal, and then hopefully you can ask anyone comfortable to turn on cameras to have a bit of a discussion about the paper and how we do handover in our emerge. And I'll focus on more of the physician data from the article as well, just given that the attendance for tonight's journal club. So the article that we'll be going through tonight was published in the Canadian Transport Medicine Association supplement in the Pre-Hospital and Transport Medicine. It's a supplement of the Canadian Journal of Emergency Medicine. The article is Clinical Handover from Emergency Medical Services to the Trauma Team, a Gap Analysis. And so I guess my first question reading the article was, what is a gap analysis? And so it's a comparison of actual performance with potential or desired performance. And the idea being that suboptimal use of resources results in a gap between ideal performance and actual performance. And it's a concept that's more familiar in a business and management world, but it applies to processes. So in this article, they're looking at handover as a process and using that lens to kind of assess emerge handover. So in the article introduction, the authors kind of introduce and remind us that handover and transition in care are a time of high risk to patient safety, and that suboptimal transition in care can result in critical incidents, reduced quality of care, and potential litigation. And lack of active listening and perceived disinterest from the receiving staff are things that have been noted in the literature previously to have reduced the quality of handover. And that results in up to 30% of information from EMS not actually being received by the trauma team. And their motivation for doing this study was that there's no previous Canadian studies kind of describing what handover looks like in Canada in the trauma setting. So this article and this study was done at Sunnybrook, which is a level 1 adult trauma center in Toronto. They have approximately 2,000 trauma activations per year. And they mentioned that the injury severity score was greater than or equal to 16 in over 50% of the cases. And so just to give you an idea, an injury severity score of 16 is an injury that's severe. So in over 50% of their patients, their worst injury is rated as severe by the clinician assessing the patient. and they were assessing patients between June and August of 2018. As far as their methods go, there was a single observer during all different shifts, so weekend shifts, weekday shifts, nights, days, and even holidays, and they were there about 40 hours per week. And they collected data based on a form that was constructed around the IMIST-AMBO framework. So that stands for Identification, Mechanism of Injury, Injuries Identified by the Emergency Medical Services, Signs, Treatments, and Trends in the patient's clinical status, allergies, medications, background history, and other information. And then their outcomes that they measured were the characteristics of the transfer, patient characteristics, information in handover as per this framework, handover process and structure, parallel conversations, which they kind of described as any conversation happening outside of the handover during the formal handover process, handover duration, questions, which they divided into interrupting questions and non-interrupting questions. And then they also took some data on the perceptions of the handover from the trauma team leaders, EMS, and the nurses in the trauma room. And they used Likert scale data for that part of things. So getting into the results, they had a total of 80 observed handovers over this 3-month period. And I think that the main points that I wanted to get here were that the majority of the patients they saw were transferred by ambulance, as opposed to the minority were transferred by air. About 2/3 of patients were from the field, while 1/3 were from peripheral hospitals being transferred in. And finally, about 1/3 of handovers had a formal handover only, and 2/3 also had an informal handover that happened after the formal handover. So looking at kind of the patients in their study, they are kind of as we would expect for trauma patients. So they're younger with a mean age of 42. There's slightly more men than women. And their injury severity score was actually a little bit lower than the average score that they described at Sunnybrook. So 13.8, which is somewhere between serious and severe. About 1/3 of their cases were MVAs, 1/4 were falls, and 1/5 were assaults, and then the remainder were made up by pedestrian injuries, cyclist injuries, and other mechanisms. The providers involved were relatively experienced, so EMS had an average of 7 years of experience. The trauma charting nurse had 6 years of experience, and the trauma team leader were least experienced out of the 3, with approximately 4 years of average experience. As far as what EMS did consistently provide in their handover, over 90% of the time they provided some form of identification. Something about the mechanism of injury, talked about injuries and symptoms and the signs. The rest of the parts of their form were much less frequently provided in the handover, and in particular the airway, breathing, circulation, disability assessment. The airway was only mentioned like 22% of the time, so we'll talk more about that later on. So as far as kind of the process of the handover, 70% of patients were transferred to the emerge bed before handover was given. 22% were done during handover, and the minority handover happened before the patient was transferred. 61% of the time there was another conversation going on in the room during the formal handover, and they noted that was associated with more interrupting questions and a greater number of total questions. 86% of total questions were interrupting. Informal handover questions inquired about information that was already provided by EMS about 58% of the time, so mostly repeating information. Informal handover lengthened the handover from just under 2 minutes to just over 3 minutes. And there was poor overall structure of the handover. So they could identify that usually the handover started with the identification of the patient, the mechanism of injury, but then it was incredibly variable after that point. There was a very low percentage of the time, 28% of the time, was there ever a dedicated Q&A after the handover. And EMS returned to a category that they'd already talked about in approximately 84% of cases unprompted. Looking at the results of the perceptions of handover, they looked at content, duration, and structure. And EMS had the best perception of handover, and trauma team leaders had the worst perception, with nurses somewhere in between. Compared to EMS, trauma team leaders were more likely to rank handover as being too long, not well enough structured, and too much information. So I did try to just put kind of lines of best fit over top of the data they provided. And you can see in this figure that there's slightly this area under the curve is widest on the too much side of things. So too much information that the trauma team leaders thought. They're marked in gray compared to EMS in blue. Considering the duration of handover, again, the trauma team leaders thought too long compared to EMS. And then looking at structure, trauma team leaders thought that there was structure lacking compared to EMS. So this is kind of my take-home slide for things that I got out of the article. So just to recap quickly, EMS providers were consistent in delivering patient ID, mechanism of injuries identified, signs and symptoms. The ABCD assessment was inconsistently transmitted. There was inconsistent structure, a lack of active listening resulting in repetition of information. High proportion of handovers with parallel conversations, increased interrupting questions, and the authors recommend that a change in environmental behavior and cultivating a culture that encourages active listening is one way to combat this. Lack of dedicated Q&A period and potentially a mismatch between EMS, what EMS deems important versus what the trauma team requires. And so some of the recommendations from the authors were to set clear expectations, which may improve succinctness and reduce the number of interrupting questions, establishing consistent Q&A period as well. And lastly, that the authors kind of conclude that there's a potential benefit in standardizing handover, co-construction of a shared mental model with input from EMS, nurses, trauma team leaders, and other key stakeholders is what they recommend. So looking at the critical appraisal, I used a critical appraisal tool for quality improvement because it was the thing that was kind of best fit this article. However, there really wasn't an intervention for the article. So I took out those parts of the critical appraisal. So with what's left, the organizational motivation, they described reasonably well, discussing the importance of handover, but they didn't really discuss the situation at Sunnybrook. So I thought it was kind of just okay. As far as the rationale, they did a good job of describing how there's no Canadian studies describing handover practices.
Back there, Luke. Fraser, I think you're unmuted.
As far as organizational characteristics, they had a full section describing their organization, so that was well done. Implementation was well done. They kind of did what they said that they were going to do. The study design left a lot to be desired. There was only one provider who did the data collection, and I did a little bit of digging, and their lead author on the study is currently a fourth-year medical student. So when this study would have happened, he would have been between first and second year. So they don't explicitly say, but I'm assuming that that's who was doing the data collection. and they didn't use any recording devices, so no audio or video to be able to go back through the cases to make sure that the data was correct. And certain elements of the handover potentially could have been excluded by EMS just based on experience. So if somebody has an isolated extremity injury, perhaps that's why airway wasn't mentioned as much during handover to keep it succinct. So the study design really didn't incorporate a way to account for that. As far as the data source, I said again, just kind of okay, just because it all hinges on one data collector. As far as organizational readiness, I did think that that was pretty good because they had high survey respondents with over 90% of surveys being filled out by EMS and the trauma team leaders. And they stated that their EMS providers wanted training and Emerge wanted better handover. So I think that there's good organizational readiness. The paper really didn't describe any sort of actionable way forward. So I thought that the spread was a little bit limited. And as far as penetration and reach as well, this study was done at a level 1 high acuity trauma center. So it's less applicable to some of the smaller peripheral centers who don't have the same setup for their trauma teams potentially. And then as far as limitations, they did a good job of describing their limitations. So a Hawthorne effect of potentially the handover going different as the EMS knew that they were being assessed. Lack of recording was a limitation that they pointed out, and their one investigator they also pointed out as a limitation. So just a couple things that I thought relevant to mention. ATLS doesn't have a standard for how EMS should do handover to the trauma team. The only thing that they mention for handover or transfer is the ABC SBAR format for MD to MD trauma transfers from the periphery to a trauma center. There are other places in the world who are looking at how to do this better. Especially in Australia, there are some good examples of different frameworks for doing this handover. So I found this MIST structure between mechanism, injury, signs, and treatment described in 2010. And then that was kind of made a little bit better in 2012 with the IMIST AMBO handover, which this study kind of used for their framework. And I thought that was kind of nice that you could see that they have pocket cards for EMS so that they can look at those to structure their handover when they come into the Emerge. So that's about all I had to say. I'm kind of hoping to open it up to discussion now. So I'll stop sharing my screen so that hopefully you can see everyone.